And of course, it's helping breathing during sleep, which is great. Now, later we can look into, well, what about the rest of the day? It's taken for granted, but perhaps if you're looking at it around the clock, you may be really dealing with something phenomenal. So, but the point is, it's this is the process, and you would either go to you'd either find your family physician and discuss it with them, and they would refer you. Or if you're searching online and find somebody like me, you might contact me, and I would refer you to a sleep physician who I have confidence in. When I say that, I mean that some sleep physicians follow the standards of care, and they introduce patients to various interventions, which include oral appliance therapy, surgery, and the use of CPAP. And some of them are one-trick pony.
Mm-hmm.
CPAP for everybody.
Yes.
You know, and that's the tendency. We all have a tendency to do the things, you know, to function in that way. It's very good for the comfort zone, but it's not necessarily in the best interest of our patient. But there's a tendency in all of us to move into that, and if people are interested in getting more full information, they're going to have to do a little more work on their own, which obviously you help prepare people for these things. And
Sure. Well, and I think that's the important public health message here is that if you have sleep apnea and you've identified a sleep care professional, you want to make sure that they aren't this one-trick pony, that CPAP isn't their only recommendation before you go and consult with them and abide by their recommendations. So you know, do your due diligence and make sure they've got the full armamentarium of the resources that are available to help you address this at the foundational level.
Yes. Now, things are changing in this in the medical system, as you know. From my perspective, it's imploding, and I think we all know that because and for good reasons. It's doing it to itself, but nonetheless, things are happening in the sleep area. Part of it is related to pressure from the fact that Medicare is soon going to be covering the oral appliance part of it, although I don't participate in any insurance of any type. But that opens up doors, and the pressure has been to serve more people, because now that the word is out, how do you diagnose them? So there are lots of entrepreneurs coming on the field. I was approached by a company that wanted me to dispense portable sleep diagnostic equipment to the patient. I have it. I dispense it. And we send it via computer, you know, via the internet, to somebody in somewhere else, could be in California or wherever, who will interpret the sleep study. One way is the technician does it. Another is the physician reads over it and gives an additional information on it, or just signs off on it. Rather than without even interviewing or examining the person. And I'm a dentist, so I don't believe, that's not my philosophy at all. The other approach is to have physicians doing it, and the in-home studies were not considered legitimate in the past, but they're moving into allowing them to be legitimate. So it's having an effect on the whole sleep community, because many sleep centers have been built, and as the information was getting out, in my area, I feel outside investment has come in and put big money into organizations opening up 3 or 4 or 5 sleep centers, where the physician sleep specialist is actually the employee. And who knows how it's going to turn out in the next few years when this home monitoring comes into play, and you don't need the sleep center for as much. But seems to me like the wild west at some point right now.
Sure. Well, that's unfortunately very common as we progress through these stages. But I'm wondering if you could help the individuals listening now to understand what the next step is once they've got their diagnostic test performed, they've been really officially diagnosed with sleep apnea, most likely obstructive, and then the next step is, you know, well, what's the next step? I mean, what's in the process?
There's one point I feel that's very important that needs to come first is,
sure,
I believe that the patient should have a consultation with a specialist first. And
what type of specialist?
Sleep specialist.
Okay.
The person who's going to interpret the sleep study and make the diagnosis, so they can ask the questions to the patient that relate to their sleep habits, their sleep issues, because obstructive sleep apnea is part of multiple issues during sleep. And although, of course, I'm prejudiced, looking at the tongue and the throat and the airway, where I feel that may be the epicenter of where a lot of it's coming from. However, a lot of things are there. There are many conditions that overlap, and the patient has no idea what's going on. And some of these sleep centers, like I just described, would go in and tell a family physician, listen, don't worry about your sleep apnea patients. Just find out if anybody feels they have sleep apnea, just contact us. We'll take care of everything. You don't have to do a thing. Well, the patient would come back to the office not having any idea of what's going on. If they meet with the sleep physician, they're going to meet with them beforehand to discuss their habits, their issues that may be relating to the sleep apnea, which obesity is obviously something that's one of them, which I know you and I are we're concerned about, and you really help people in dealing with. But very often that apneic person can find it very difficult to even lose weight because of the struggle involving the apnea. When the apnea is resolved, the weight loss seems to kick in nicely. So they work hand in hand. But the point is, they need to understand those things. And then after the sleep study, they'll meet with the sleep physician, who will explain to them the results of the sleep study, what it means, and the implications in treatment. So I would say never, if you have a physician who wants to send you directly over to a sleep study, tell them, I don't want to do it. I want a consultation with a sleep physician.
Okay, so that's a good first step. So after they've had their consultation, what do they do after that?
Then that's going to look at treatment options, and that would be discussed. And of course, there's protocol and priorities within the sleep community regarding how you approach care. The oral appliance approach has been as recognized as part of the standard of care since 1995 or 96. And then again, in an update on the standard of care regarding oral appliances in 2000, 2001, it was updated. But initially, oral appliances were recommended potentially as a first line of approach for mild apnea, but for moderate or severe apnea, the CPAP should be considered first. And then if that's not successful, surgery or an oral appliance should be considered. After more research was done and available to evaluate, in 2001, the standard indicated that oral appliances could be looked at as the first line of approach for mild and moderate sleep apnea. However, for severe sleep apnea, a CPAP should be considered first. And if the patient is, now this is important to hear, if a patient is either unable or unwilling to utilize nasal CPAP, then an oral appliance should be considered. So that's how it's written. Now, how third-party providers relate to this may vary depending on the third-party provider, and I would call them the insurance companies who are dealing with the money, the payment aspect of it.
Sure, which is an important issue.
They do weigh in as far as the patient's compensation.
Oh, absolutely. So is that the most recent recommendation, the one you just quoted?
Yes, it is.
All right, so that was about 10 years ago almost.
Yeah, now that you mention it.
So they're hopefully up for a revision of that at some point.
And again, let me, I almost want to backtrack a little. It could be 2005. I'd have to look that up.
Okay.
But that's most recent.
All right. So, but according to the experts, the recognized conventional experts in the field, that no one's going to dispute or have an argument with, is that the oral appliances in non-serious cases should be considered as a first-line alternative.
Yes.
Or a first-line option.
Yeah, as a first-line alternative. Now, again, if the patient's preference will have an impact if the patient falls into these categories, because the sleep center is used to working with the CPAP. Some physicians who are working with this have a lot of experience working with dentists, working with oral appliances. Some of them have none at all, and some of them have very limited experience. And based on the knowledge and skills of the dentist working with it, with the oral appliance, and the patient that the physician has observed, that can affect that whole experience can affect the perspective of that patient. Of the physician, It can affect how the physician looks at it. So the patient's perspective will have an impact, and then the physician is going to already have a what I call an already listening regarding this. But all in all, it allows the patient to look at influencing how they're cared for, which is important because healthcare is how we care for our health. You and I are wonderful advisors to people, and we're resources, but they're the ones who care for their health. And,
all right, well,
and as you and I know, that's how this can be utilized by working.
Yeah. So for the obstructive sleep apnea, for those who are overweight, which is probably the majority of people who have obstructive sleep apnea, I would imagine,
Actually,
then clearly.
not.
Oh, it's not. Okay, good. So I'm off. But for those who are overweight, then clearly the solution is relatively straightforward. I mean, they have to really radically restrict fructose in their diet. They cannot have fructose. That is my view, and many other experts, that is the number one reason that people are obese. They're having too much fructose. So they've got to do that, and they've got to get their exercise and cut out the grain. So that's pretty straightforward, and we've got tons of information on the site.
But for
I'm sorry?
All they need to do is listen to you.
Well, it's a matter of listening, addressing the psychological variables. There's a lot of components, and it's not necessarily easy, but it's simple.
Yeah.
It's simple.
Yeah.
So it is a straightforward process. But the more complex one is in the obstructive sleep apnea is those who don't have a weight issue, which you just explained is the majority of people.
Well,
then
let me come back to that, if you would.
Sure.
If I don't know the statistics, but I know that I have a heck of a lot of patients who come to me who are not heavy.
Okay. Well,
so
that's fine.
So the originally the sleep apnea patient was looked at as a great big heavy person. There was a name for it back in the old days. It was like a person maybe 300 or 400 pounds, and that
morbid obese.
Yeah. So that was the original concept. That's probably back in the late 80s and early 90s. But as we see it now, we're beginning to recognize that more and more we're seeing more and more people who are not morbidly obese, and many who are not obese who are relating to it because the fat is a factor. It does impact it, but the primary issue is the tongue. Mm-hmm. And the fact is the fat in the tissue is definitely a compounding factor that couples with it.
So if you're an individual who's been documented to have this, you've gone through this sleep study process, you've been officially diagnosed, you're not overweight, or that's in the process of being addressed, and then you've had your consultation with the sleep specialist, and then it's off to the dentist, the properly trained dentists like yourself and others who can really properly evaluate and recommend and design an appliance. So can you go through that process of what that looks like and what your recommendations are?
Okay. Well, okay. Now I need to point out that I may be considered a maverick in this area.
Okay.
I helped develop the original standards of care for treating patients with this. From my perspective, that has not been. I have not been popular in that area amongst my colleagues. I keep somewhat of a low profile in the organization now because I don't want to upset people. But there are over 100 appliances, and when I wrote my book chapter on that in Fairbank's book,
wait, that's important. There's 100 different types of appliances.
There probably are. And when I say different types, if you look all over the world, there are probably 100 different oral appliances, most of which move the jaw forward.
Okay.
Some of which hold the tongue forward without moving the jaw forward in particular. And there's one out that depresses the tongue, which I haven't worked with, but I have concerns about its impact on the body just because of how I feel it would impact the autonomic nervous system, holding the tongue in a depressed state.